morning, and we're going to start things off with Dr. Cruz, who will be speaking about the role of the plastic surgeon in managing third nerve palsy.
Sure.
And Augusto is a great speaker and has good things to say.
Okay. Okay, thank you very much, and it's a real pleasure to be here. I'm so happy to find so many friends. Thank you very much. It's an honor. I'm going to talk about how we oculoplastic surgeons can help our colleagues to fix something that is very difficult in third nerve palsy. So we all know that third nerve palsy that has many etiological factors. This is not the subject of my talk. The problem is when everything is already permanent, definitive, you have to fix the complications of the third nerve palsy, and you have to do surgery. And the goals are to have a good alignment of the case with the contralateral line in unilateral case, and we have to do total surgery. The problem is that when you have a third nerve palsy, all those muscles are gone. You just have the lateral rectus and superior oblique, and the elevator is not working very well. And your patient went up with a fixed exotropic eye and no levator function. So how can we fix that? I mean, we have to fix the eye position and the ptosis. And if you see here, normally those patients have huge frontalis overaction. So we have to use the frontalis muscle to fix the ptosis. And a huge ptosis with no valves. MRD is very low, and how can we do that? So it's not very easy. So the surgical management, starting with the eye position, the first thing that we should do is to inactivate the lateral rectus muscle, okay? And there is a lot of procedures that have been done, but I think that the most predictable and useful procedure is to inactivate the lateral rectus using the lateral wall. So this is a very simple procedure for an orbital surgeon. It takes 15 minutes. You do a lateral canth incision, expose the rim, get the lateral rectus, and transpose the lateral rectus to rim, suture the lateral rectus to rim, so the lateral rectus is gone. Good. So something happened because the eye moves a little bit medially, but not too much because the X of the orbit are divergent anyway. So here is how we do that in my hospital. And then we have to rotate the eye medially. Okay, this is more complicated. People have tried to do extraocular muscle surgery. All those procedures, in my opinion, they do not work very well because lateral rectal transposition is such a difficult procedure and does not work very well. And superior oblique transposition also is not a good idea. And the medial rectus is gone, so I think that the best procedure is try to fix the eye on the medial wall of the orbit. And that's why I think the orbital surgeon goes and do a good job doing that. People have tried to suture with fascia lata, using sutures, titanium plates, periostal flap, and superior oblique pendulum. So, as you can see here, Bob Woodbeck published that a long time ago to use a periostal flap of the medial wall. In my opinion, it's not so easy because the periorbita here is so thin. If you try to dissect that, probably you're going to go inside the ethmoid sinus. It's going to bleed. Not very easy. That's why people start using a mini plate instead of a flap. Fine, I think that's a good idea. But you have to have these mini plates. You have to use the screws on the anterior lacrimal part of the lacrimal fossa here. I have never done that. But I mean, I think it is good, if you have all those things, it's fine to try to fixate the growth on a mini plate. Using the chemical is not good because people have tried that in Brazil. It did not work very well. With time, the eye goes back to the divergent position. And one surgeon in Mexico tried to use the superior oblique tendon. Wow, superior oblique tendon to fixate the eye on the medial wall. This eye is going to rotate hugely. It's not a good procedure. So don't do that. I think nobody is doing this, but have been already published. So one of those nights that I'm not sleeping well, I say, well, why cannot use the superior oblique muscle, not the tendon? If you look here on the left figure, superior oblique is right there on the medial wall, and it's very close to the ethmoid anterior artery foramen. If you see the anatomy, this red arrow is the anterior ethmoid artery entering in the ethmoid sinus. You have here two veins, a branch of the angular vein, supraorbital vein. Those two veins form the superior orbital vein. Okay, so I can do that. And the idea is to find the superior oblique muscle, not the tendon, put some sutures, release the muscle from the trochlea, and then if you do that, you can transpose the superior oblique muscle to a medial rectus position. And this is good because if the superior oblique muscle is working, I mean, as all rectors are gone, including the lateral wall rectus, because you fixate the lateral rectus to the lateral wall, the eye gets hypertrophy. So to release the superior oblique muscle from the trochlea, inactivating this muscle, I think this is a good procedure. And then, how we do that? We all do, I mean, at least I do a lot of transconjunctival medial approach to the orbit. If you look a little bit here, you see the anterior ethmoid foramen and the superior oblique, you know, is here. It's very close to the anterior ethmoid artery. So here you can see the superior oblique muscle. We use a strabismus hook. We get the muscle, we cut that muscle, put some sutures, and bring the superior oblique muscle down to the medial rectus position. And we made a conjunctival flap, and then you anchor your eye on the muscle belly of the superior oblique muscle. So the muscle is alive, is not inactivated by the disease, and it gives you a lot of tissue to fixate the eye. So, and then you have to fix the doses in the same procedure, of course. This is more complicated because there is no Bell's phenomenon. The eye is completely stuck in the orbit, so you cannot raise the upper eyelid a lot. If you raise your upper eyelid, he's going to get lagophthalmos and corneal issues. So what I do is this is a procedure that John Shore used to do. I just put two pieces of, or one piece, sometimes just one piece, but most times two pieces of autogenous fascia, and I make a linkage. I'm not raising the eyelid. Please, do not raise the eyelid. Just make a connection, a linkage between the lesion and the frontalis muscle, because he's already overacting the frontalis muscle. So once you do that, with time, this autogenous fascia tend to contract, and he's going to be able to open the eye doing what he was already doing, that's contracting the frontalis muscle. So we published that in OPRS 2 years ago, already 6 years ago. Jesus. I'm getting old, you know. But anyway, in my myogenic patients, and they do very well in my opinion. So here's some case just to finish. This is a baby was born with congenital cerebral palsy, and one of my colleagues saw my procedure, and he did that by himself, fixate the eye in the superior oblique muscle that was displayed from here to here. Nice result, nice result. and then he's already planning to do total surgery. Unilateral, even in unilateral case, you see that the baby is already using the frontalis muscle to lift the eyelid. So here's a bilateral case. Look at how the frontalis muscle is so over contracting, huge hyperaction. So we did that bilateral. The right eye is in a better position. It's still a little bit exotropic here, but she's so happy that she doesn't want to have surgery anymore. And she is able to open and close the eye. Because if you do something like a lever resection here, or silicone, or whatever, I think that's maybe the danger to have corneal issue is pretty high. So this is another case, much more complicated, because the boy has some other neurological issues. We moved the eye to the better position. He's using the eye to open the lid. I think he's going to do better. If he doesn't do better, you can go back there and resect a little bit of fascia and do a little bit more tension on the eyelid. I think he's going to do well. And this is my last case that I have photographed. We have 6 or 7 cases with this technique. Incomplete bilateral third nerve palsy. This eye is completely exotropic, but it was the better eye. So we did the procedure, and she's doing very well, opening the eye with a better position of the eye. So I think, in my opinion, if you want to move the eye from extreme exo, to a better position, first remove the lateral edge, suture the lateral edge to the orbital rim, and then try to use something to bring the eye, to anchor the eye immediately. I prefer to use superior belly muscle, not the tendon. I think this is a good procedure. Thank you very much.
So you have a minute left here, Elizabeth, so I just want to know, how much ibuprofen and Tylenol do you have to take before you can think about strabismus without getting a headache?
Well, do you know, before doing oculoplasty, I was doing strabismus, so
Okay.
it's just, it's not a big deal.
Bob, can I ask?
Yes, I think.
Why not just disinfect? Why do you have to disinsert and do something to the, and fixate it to the orbital? Why not just releasing it?
Well, people have tried that. If you just detach the lateral edge from the eye, I don't know exactly why, but you still have exotropic deviation. I think the lateral edge fixed somewhere in the orbit, and you know, the axes of the orbit are so divergent that even with a small lateral action, they go to the position. So it's better to inactivate the lateral edge, in my opinion.
Thanks. Our next speaker is Dr. Graue, and he's going to talk about open decompression in his model.
Thank you, Rob. Good morning. Thank you very much, Luigi, for the invitation. It's been a great meeting. And I'm Dr. Gerardo Graue. Wait, it's not... okay. So I'm Gerardo Graue, head of the Oculoplastics and Orbit Department at Hospital de la Luz in Mexico City. And as we all know, the slogan of this meeting is back to the roots. So I was wondering, I made myself this question, how can I teach orbital decompression to my fellows, how far back do I have to go? So I think kindergarten is the answer. So in kindergarten we used to play with clay and do models and construct, so that's what I asked my fellows to do. I asked them to bring some clay to the hospital and make an orbital model in a skull. So they were wondering why I was asking this to them. This is Hospital de la Luz ORs. Actually, we are now celebrating our 150th anniversary. It's one of the most antique eye hospitals in Mexico and Latin America. And we decided to do a hybrid video. So I'm showing you a case of a patient with thyroid eye disease. She has a big proptosis, and usually only the surgeon is the one that gets to have a good exposure to the surgery, and maybe residents don't see that much, or maybe they don't really realize where are we working. So that's why I decided to do this hybrid model for orbital decompression surgery. So we are starting with a balanced orbital decompression with the medial wall. We are doing a transcaruncular approach. We just incise under the caruncula, and with electrocatheter we make this incision. We extend it all the way to the periosteum of the ethmoid bone. So here is our model, so everybody can watch what we are doing. And as we incise first the periosteum, we have to remember there are some important anatomic landmarks that we have to remember to avoid any damage to the fossa cranialis. So we lift the periosteum with a Freer elevator, and what we want to do here in this step is look for the fronto-ethmoidalis suture and to the ethmoid arteries. We know there's some memo techniques to learn where are these arteries, and when we localize them, we can go under the arteries to start our decompression. We never go up, because we are going to go to the fossa, to the cranial fossa. We start with an osteotomy. We can start it with that same Freer elevator, or with this aspirator, or even with a carry. So it depends on what we have in the OR and how we are used to do that. We make the first initial osteotomy, and then we extend. And I like to go all the way to the inferior pillar of the orbit. So as you see, this bone is really, really thin. It's really easy to break it. We take also the ethmoid cells, and at the end we are going to see which is the depth of our decompression. We have also to take care of the lacrimal sac. So the osteotomy goes back from the lacrimal bone to the apex of the orbit. Here is how we trans-illuminate and see the size and the anatomical position of our osteotomy. And now we open the periorbita, we let fat protrude, and that's how it ends. That was the ethmoidal artery simulation. And we are doing now the lateral wall. So we use a crease-slit incision, the traditional right incision, and with blunt dissection we get to the orbital rim. We open it with the same cautery. This is very easy to see, everybody can see it in the OR, but when we are going deeper, it's going to be more difficult, light is going to be more challenging. So we are doing this same hybrid model. And we really don't want to mess with the anterior orbital rim. We just want to go to the deep bone, where that's the place where we're going to get the best decompression. If we do it before that, we're just going to be in the temporal fossa, and it's not going to work, and it's going to be more bleeding. So we incise the periosteum, we lift it with the same Freer elevator, and now we have two other landmarks, anatomical landmarks here. First is the fronto-zygomatic suture that you can see in the video, and the other one, the other more important, is the zygomatic sphenoidal suture. So we are going to start our decompression from the zygomatic sphenoidal suture, we use a striker saw with round burrs, 2 millimeter and 4 millimeter cutting. And we start with the cortical bone. We take out the cortical bone, and then we can change our burr to a diamond-shaped burr that is less propense to damage the meninges if we get there. So we are gonna see first dark bleeding. That's where we know that we are in the trabecular bone. We have already removed all the cortical bone, and then we do this change in burrs. If we don't, we might have an accident just like that it's seen over there. If this was real surgery, I would really go I would have a heart attack. Then we extend the decompression. It's around 1.5 centimeters of extension. And when we already finish the trabecular part of the bone, there's also a change in the brightness of the light of the posterior cortical bone. So that's another way to notice where you are. It's around 1.5 millimeters. There's the measuring in the height. There's another technique that we can use. This is a technique that Bob Goldberg describes, doing a lacrimal keyhole. This also helps us see clearer. I used to do this before, now I don't do it anymore. I think it's not really necessary, but sometimes it might work, especially if the orbit is too tight. So in this technique, you take part of the orbital rim, the superior orbital rim, where the lacrimal gland is. Bob says this helps also relieve some pressure of the orbita, and then you get a better exposure. You want to see, you have to take the periosteum, and you want to see the inferior hendidura, the inferior fissure. Great, thank you. So it's the same, we start drilling the cortical part of the bone, around 1.5 millimeters from the rim, where we can localize the suture. And in this technique, I'm not using the burr to keep drilling the trabecular part of the bone. I use the same FREER elevator. This can be used. It's safer. It's a little bit more, it takes a little bit more time, but it's a little bit more safer. You just take all the trabecular, and also this is the part where there gets the dark bleeding. You can use maybe some wax for the bone if it's necessary. Usually it's not. And when you take all these trabecular, the bleeding stops. We measure it, just around 1.5 millimeters for the complete removal of this part of the bone. And then we can transilluminate, and there we see how is only the cortical posterior lamina. So these are our results in the preoperative, and in 1 month post-op. This patient has to undergo lead surgery for completing her rehabilitation. And well, we always use this approach, first treating the exophthalmos by orbital decompression, then if it's necessary, treat the strabismus, and at the end, treat the leads. And I think it's the best way to manage this. So the conclusion would be, back to the basics, or back to the roots. You have to know your anatomy. Grazie.
Very much. Questions until session.
I'm off to be the next speaker.
And whoever's running the clock, please start that on time when the speaker starts speaking. And our next speaker is Ilse Mombards, who's an expert in orbital inflammation, and she's going to talk about M for myositis.
So thank you, Bob. Dear audience, thank you very much for showing up so early on this beautiful venue. But I'm going to talk about indeed inflammation, particularly of the extraocular muscles. So typically, these are cases you see at emergency, usually Friday evenings, but still also at emergency. A patient who has particularly pain and double vision. These are two symptoms that the patient cannot wait to come at another time of your clinic. So here we have a younger man with a red eye, but particularly pain and double vision. And if you look at the motility, you always have to keep calm. The patient is not calm because he's in a shock of seeing double, but you see that the abduction of the left eye is limited. We call it a paresis. And you also would think that there is a limitation of the adduction. However, that's often due to pain. So because of pain, they stop induction, but that is not a restriction, so it's a pseudo-restriction. If we look at the scan, we see indeed what we assumed. This was a myositis, an acute myositis of the lateral rectus muscle. We call this idiopathic, which is of course at that stage maybe not completely correct, but it's the typical triad of symptoms of an acute, painful, restricted muscle, paretic paresis, idiopathic orbital myositis, and usually also in a younger patient. We actually always see a monomyositis. We don't see several muscles affected. I will later tell you why I feel this is no longer idiopathic. But so it's always one single muscle affected. Here's also a younger girl, and her abduction is limited, not severely, and because she has quite a large, quite a serious inflammation of her lateral rectus muscle. And when you ask her then to do the other movements, particularly adduction, which is painful, she stops. But do not confuse this with paresis or restriction. It's antalgic. It's because of pain. The stretching of the inflamed muscle is very painful, as you know after you have done an exercise. So a mild case of idiopathic myositis will have its motility a little bit disturbed, not completely, and will have some pain, but still doable. Particularly at night. Pain is usually at night. All inflammation is particularly at night because of your drop in cortisol levels. But anyway, over a course of 6 weeks, normally this actually all recovers. Motility will recover entirely and pain will disappear with treatment. However, we can also have very serious cases of monomyositis. The pain is immense. People have really been on high doses of painkillers before they come to see you, and the motility is seriously disturbed. And also this will get better, but here we really need to consider the natural course of a myositis, which may take up to 3 months, 12 weeks. So here, for instance, we have a patient, again, a younger boy, with a serious limitation of his adduction. You also can already assume it will be the medial rectus muscle, because you see the conjunctival redness overlying the insertion of that very muscle. And indeed, you see this inflamed muscle in an acute setting. This is the typical case of an idiopathic myositis. We treated him, was okay. A year later, he came back, but here he has a different motility problem. It's vertically. He has a vertical problem. The elevation is limited. Depression is normal. So we have here an inflammation of the superior rectus muscle. And this is called myositis migrans, or this is a monomyositis. So it's migrating over the course of recurrences. So recurrence is not usually the same muscle. It's often another one. It can also be in the other orbit, by the way. So for instance, here we have the girl on the video. That's the first time she gave lateral rectus muscle myositis. 2 years later, inferior rectus muscle, and a couple of years later, the medial. So migrating myositis. Very typical. Now, when we're treating these patients, we have 2 goals in mind: relieving the pain, but also restoring motility. And here we will distinguish whether we have a mild case or severe. Mild we can safely treat for only 6 weeks. And it's a severe case with severe pain and particularly severe restriction of motility. You actually should, the 6 weeks course will be insufficient. So here we have a patient, I consider it mild. You just have to believe me, but he didn't have much pain, and he had a pre-operatic muscle on the lateral rectus muscle, and he was treated with a 6 weeks course of NSAIDs, and he recovered entirely. Same for the patient who had an elevation problem, but not so much of inflammation of the muscle, not much pain. He recovered entirely after a course of NSAIDs. However, on one of his other recurrences, the treatment was insufficient and he required oral steroids. Now I'm going to give you the recipe how you can convert an acute myositis into a chronic myositis. Really? This is very, very important. A chronic recipe is you start with a too low a dose, you quickly taper, because you're actually treating with pain, you think, and you give it for too short a period. This was a lady who came to me after years of having this chronic recipe. She was given a low dose, too low, quickly tapered, because she was better. She was really better. But she told us that each time she required again her painkillers when the prednisolone was stopped, really stopped. So this was going on for 2 years. This is a so-called chronic myositis, because the prednisone is given as tic-tacs. It's called Satan's tic-tacs. Indeed, it really works within 4 hours. So they take it as painkillers, but indeed, we don't give it as a painkiller, we give it as a proper recipe for inflammation. So the chronic recipe is actually just giving the prednisone for treating the pain, but in the meantime actually ignoring the myositis, the process of a 12 weeks inflammation, which you're going to expect to happen in the muscle. So we have, the proper recipe means 12 weeks. 12 weeks. Even if the patient is better, even if they start to develop some side effects from prednisone. So, a proper recipe, and here you should take the photos, not from the chronic recipe. It's in the mild case, actually you don't know really when it's mild or severe from the very beginning, but you can always already start, in the meantime, before you get your CT scan taken, with a mild course of ibuprofen, high dose, 1,800 milligrams a day, but you have to slowly taper it, just like you do with steroids. 2 weeks high, and every 2 weeks you slowly taper. And usually that's sufficient in a mild case. However, if this is insufficient, you see this, you have to go for the severe recipe, which is methylprednisolone, 1 milligram per kilogram per day, slow taper, so every 2 weeks you taper, and for months, 3 months. So here, for instance, this lady, she needed in the end the steroids, and she developed her side effects of the steroid fascias. But anyway, she required it, and it was a treatment which was just a lifetime treatment. You don't develop the chronic myositis. So, are we talking about idiopathic myositis? Well, in this case, you should always keep in mind that when it's atypical, when the triad of acute pain in a single muscle is not, a paresis in a single muscle is not happening, you actually might deal with another kind of muscle disease. So when there's no pain, it's not an idiopathic myositis. When it's slow onset, when you have several muscles affected, when there's a focal enlargement in the muscle, when they are extremely enlarged, just out of proportion, and also when other structures are involved, particularly lacrimal glands, and when, of course, there's a history of malignancy. But when a patient is also not responding to a proper course of steroids, we might also consider we need to look for another diagnosis. How do we biopsy? And I still have some time I see left. There is we just always consider the whether the muscle, where the muscle is actually enlarged, and we just draw a line for everything on the anterior third of the muscle. The posterior third is approached differently surgically. The anterior part we will just address like squint surgery, like Augusto would then actually very well do. However, it's also very good for the posterior two-thirds of the muscle because there we need an orbitotomy procedure. Which muscle are we going to choose when there are several muscles involved? You choose the one that is not only the easiest accessible, but with the least lesions going to happen. So it's always the inferior complex, particularly the inferior oblique muscle is exceedingly easy to access, or the medial rectus muscle or inferior rectus muscle. So here we had a patient who had this migrating myositis, but became poly. He had several muscles affected, but this is, I'm seeing him already for 15, I have been seeing him for 15 years, then a muscle, then another one, then several muscles affected, and then indeed you think this is no longer idiopathic myositis. So he finally got a biopsy taken from the inferior rectus muscle, and, inferior oblique muscle, and it turned out to be ICOS-related disease.
This is like
The squint surgery can be certainly done when also the anterior part of the muscle is, when the anterior part of the muscle is affected, and this is very simple, which actually also is even better to take at that stage to use a biopsy punch, because you have very few artifacts on your biopsy due to the surgery. And the orbitotomy procedures, it depends which muscles you need to biopsy. For the superior complex, you can go by the skin crease, which was here done for the superior oblique muscle, turned out to be a metastasis. The lateral rectus muscle, this gentleman had a really a nodule in the lateral rectus muscle and no pain as well. So he got a biopsy by the lateral cantotomy, orbitotomy, and then the inferior rectus or the inferior oblique muscles can be approached via the lower fornix, which was the case in this lady with a history of malignancy, and she needed a biopsy to be taken very posteriorly in the inferior rectus muscle, turned out to be a metastasis. The medial rectus muscle can be approached by a retrocameral procedure here as well, a very nodular, very just no myositis. You just know this. He has no pain. He has a history of malignancy, and it was a metastasis of a well-known lung carcinoma. So this is my conclusion, just for time. So we have in the idiopathic cases considered certainly the NSAIDs first and steroids, high dose, slow tempo. So that's the dial M for myositis. It's the maximum dose you have to give. Thank you very much for your attention.
Thank you, Ilse. And I should mention that we're going to do questions at the end of the session. You can enter them on the app at any point during these talks, and then we'll go over them at the very end. Thank you. Our next speaker is Vita Ismaili, and she's going to give us an update on adenoid cystic carcinoma, the lack of gland survival.
Thank you, Bob. Thank you for inviting me. So I have a talk on lacrimal gland adenoid cystic carcinoma. I have no financial disclosures. These are my current affiliations. I retired from MD Anderson after 26 years, for those of you who are curious and may not know. My current hospital affiliation where I do surgeries is Houston Methodist Hospital, and I have some academic appointments as well. Much of the work I'm going to discuss, though, was done during my years at MD Anderson, although my interest in this topic continues, and I do have still an oncology practice. So adenoid cystic carcinoma of lacrimal gland is an exceedingly rare cancer. I think we all know that and appreciate that, but of course, because of the importance of it as the most common malignant cancer of the lacrimal gland, it does get appropriate attention in our literature, and but when I tally my cases over the course of 26 years at MD Anderson, and since my departure about a year and a half ago, I treated 58 cases. So that just gives you an idea of just how rare that cancer is. And I have a primarily referral practice of orbital oncology. This is a cancer that unfortunately still leads to metastasis and death in about half of our patients, despite all our efforts. It has a tendency for perineural invasion. In fact, most pathologists that are familiar with anocystic carcinoma would tell you that if they don't see perineural invasion on the surgical specimen, they just assume that they missed it, that it was in the sections. They just happened not to see the section that contained perineural invasion. And the places where we see metastasis is lung and bone, most commonly, but it could be any organ, indeed. So I'm going to show you some cases just to kind of bring us to the point of survival and how do we decide what type of surgery we do and things like that. This is and also to highlight that some of our standard teaching really don't hold. If you treat enough patients with anocystic carcinoma, you'll see that there's a lot of overlap in terms of clinical and radiologic features. This is a 71-year-old woman, presents with mild proptosis, some fullness in the right upper eyelid. Symptoms have been going on for 8 to 12 months, denies pain, and these are her MRI images, a relatively well-circumscribed lesion. For all the world, it could be a pleomorphic adenoma. I think, in fact, the presumed diagnosis appropriately should be pleomorphic adenoma, and for obvious reasons, because we don't want to do an incisional biopsy in a pleomorphic adenoma. So, after a gross total resection, the diagnosis was adenocystic carcinoma, and this actually is not so uncommon. I think about a third of cases, if you look carefully at series. So at this point, then, she needs additional treatments. Again, because of the propensity of perineural invasion, because of the risk of microscopic residual disease, in the case of an infiltrative adenocystic carcinoma, we always offer adjuvant radiation therapy. Here's another case, a little more obvious case, 60-year-old man with progressive proptosis, a little more rapid onset of symptoms. His particular lesion has a little bit of well, it has definitely more of an infiltrative pattern. Let's see if I can point with the laser. So on this coronal, we can see that it is really not as well circumscribed as the previous one. It is sort of beginning to wrap around the lateral rectus muscle and superior rectus muscle, and it has perhaps a slightly more posterior extension. This patient was treated with an incisional biopsy, adenocystic carcinoma, cribriform tubular pattern, which is the most common variety. This is a patient of mine from 2017, so I have long-term follow-up on him. So he had eye-sparing surgery, followed by radiation therapy. You can see his MRIs post-op. We don't see any gross residual disease. He has some lateral rectus restriction from dissection near the lateral rectus muscle, which happens in the majority of patients who have eye-sparing surgery. And actually that photograph is from when he's in the middle of radiation therapy. You can see the immediate effects of radiation. I followed him carefully, and he did very well until June of 2024. From 2017 to 2024, he has had no local recurrence, but we found his lung metastasis in 2024. And this is not an uncommon finding. So you have good local control, but we still get metastasis. Here's another case, 55-year-old man. This is an interesting history. He complains of progressive, he's an engineer, but has been obviously ignoring this problem. He gives a 3-year history of progressive proptosis and some diplopia, has some pressure sensation, but denies actual pain. He has some loss of vision from choroidal stria from this mass that is, again, fairly well circumscribed. I think we could say this could be a cellular pleomorphic adenoma. In fact, I have had cases just like this, radiologically, that are the cellular variety of pleomorphic adenoma. And this one also turned out to be adenocystic carcinoma. I'm really glad I did a gross total resection up front, because it could have been a pleomorphic adenoma, but it turned out to be adenocystic carcinoma. And he also had adjuvant radiation therapy. and I have 25 months follow-up without any recurrences. So eye-sparing surgery, I think this concept really now is fairly well accepted throughout the world. I think many centers have published their work, but really just refers to meticulous surgery to remove all the little pieces of the adenocystic carcinoma, particularly because some of them have previously had incisional biopsies, and then by the time they're referred, there is infiltration into the surrounding soft tissue. And if the bone looks abnormal, you need to take it off, regardless of whether you think you can do access to the orbit. If the bone is involved, probably it should be taken off. And also then followed by radiation therapy. So it's really usually this surgical specimen that I'm showing in the middle, let's see, on the laser. This petri dish with all the little pieces is actually really typical because you have to do meticulous surgery to get every little piece of the cancer out, then radiation, and radiation usually starts 4 to 6 weeks later. There is ocular toxicity associated with 60 grays of radiation near the eye, and to various degrees. We published this, for the sake of time, I won't be able to cover all of it, but suffice it to say, in the modern day of availability of anti-VEGF injections, I think in addition to very careful surveillance for recurrence, we also need to do careful surveillance for radiation-induced retinopathy so that we can offer these treatments by a retinal specialist as early as possible. And with that, I think the majority of patients maintain some degree of useful vision over time, some of them even 20/40 or better, and certainly we don't have loss of the eye because of radiation toxicity. One more case, I'm showing you the sort of spectrum of disease and then where we are in terms of survival. So this is a 41-year-old man, presents with a biopsied lacrimal gland adenocystic carcinoma, has had 6 to 8 months of progressive proptosis and symptoms. And this MRI, of course, I think we would all agree, rather than just a little bit of infiltration of lateral rectus muscle, this tumor is involving really all of the extraocular muscles. It's crossing the midline, and it's also, of course, spilling out into the temporal fossa. And this patient, at least in my opinion, right up front, should be offered exenteration. We did offer him notch-directed targeted therapy, but unfortunately did not make a difference in terms of the size of the lesion, so he went on to have exenteration. And I include this case to say that even today, with all the amazing availability of from multiple centers, good outcomes with eye-sparing surgery, there are still patients that require orbital exenteration. And at MD Anderson, we started offering eye-sparing surgery and radiation since 2007. This was from 1998 when I arrived to 2007. Lots of convincing of our radiation oncologists that this can be done. We should do this. It does make sense. It beats exenteration. It doesn't make a difference in terms of survival. And so we started to do that since 2007. And I would say since 2007, about 70% of our patients are getting eye sparing. The rest of them are still needing exenteration because of the way they present. And we know now from our center, from various different publications, that the local recurrence from eye sparing followed by radiation versus exenteration followed by radiation are about the same. But of course, there's a bias for smaller lesions, more resectable lesions to go with eye sparing, and the bad ones have exenteration. So there's an inherent selection bias. And these are our survivals. In fact, most recent publication, which is based on my work at MD Anderson, 52 patients with adenocystic carcinoma of lacrimal gland, we have better survival than historical controls that have been used in many publications. So 5 and 10-year disease-specific survival was 74% and 67%. That's actually fairly decent for this particular cancer. And our local recurrence rates were similar in the two groups, I would say. But again, keep in mind, if the eye-sparing group looks better, both in terms of survival and in terms of local control, it's, in my opinion, because of selection bias, because the bad cases are getting exenteration. And there is a correlation with T category, which ones get eye-sparing or not. Histologic subtype matters in terms of survival. And of course, we did a bit of analysis, eye-sparing group versus exenteration. And we did come up with sort of radiologic features that could help. But again, this is retrospectoscope. I was the surgeon who decided who gets what. So obviously it's a biased set of retrospective analysis, but still you can start to get some trends. T-stage matters, smaller size, extension to distance from the superior orbital fissure. I asked that question, and indeed there's a statistically significant difference between the two groups. I think we have some urgent clinical needs for this disease, the most important one being finding drugs that work. Not the standard chemotherapy, because that clearly does not work, but targeted drugs. Notch, unfortunately, despite all the excitement, seems to be mostly stabilizing. So we definitely need new drugs that work, and this cancer has paucity of mutations, so it does not respond to immune checkpoint inhibitors, unfortunately. And we also have a need for earlier detection of metastasis, and to that end, there has been progress made with liquid biopsies and have been published by a Chinese group. So take home, I think I'm right on time, hopefully. I believe that eye-sparing surgery is here to stay for adenocystic carcinoma, but we have to remember that still, for about a third of our patients, exenteration plays a role. And regardless of the type of surgery, everybody should get radiation because of the high prevalence of perineal invasion. And I think experience and familiarity with this type of surgery for this particular cancer and other carcinomas of lacrimal gland for that matter does matter, and as well as experience with delivering radiation post-op. I think that's really important. And long-term surveillance, both in terms of finding recurrence as well as finding distant metastasis and ocular toxicity if we're going to do eye sparing followed by radiation. And of course, I think there's an urgent need for better drugs, and I hope that in what's left of my career, I can contribute to that, because I think that's what's missing, really, for this particular cancer. Thank you.
Thank you, Gita. Our next speaker is Dr. Uday, who will be speaking about enophthalmos post-complex orbital trauma. And again, questions you can put into the app, and we'll deal with those at the end.
Good morning to all of you, and thank you, Luigi, once again for this wonderful meeting and this kind invitation. I'll be speaking on enophthalmos post-complex orbital trauma. So what we are going to talk here today is post-complex orbital fractures which involve more than two walls. So enophthalmos can be either because of an increase in the bony orbital volume or because of a decrease in the soft tissue. The challenges that we face in these cases is that the orbit is very scarred and fibrotic, the dissection is very challenging, and removal of the existing allografts can be extremely difficult because sometimes they get osteointegrated and it is difficult to even open the screws in some of the cases. Now, if you have a case like this who has a right enophthalmos, he's had surgery in the past, facial-max surgeon has reconstructed the orbit, you can see that the floor medial wall is still not repaired and the zygoma is not in place, which you can see on the axial scans. So what is our next step? Can we plan an intraorbital fat injection, or should we redo the zygoma? Should we do the zygoma, floor and medial wall, or should you only do the floor and medial wall as oculoplastic surgeons? So what we did here is we moved the zygoma. So whenever your body of the zygoma is intact, it is a good idea to move it so that your anterior projection is symmetrical with the other side. But if your body is comminuted, that movement gets very difficult, and I'll show you the subsequent cases. So I think I will move the slides myself, please. So now this is another, I will move it myself. So this is another patient who has enophthalmos hypertropia, and again bony reconstruction has led to a good result. Another patient with bony fractures, enophthalmos as well as ptosis and telecanthus, and he did well after surgery. I don't know why the slides are moving by themselves. Another patient pre-post and another one pre-post. So what I want to drive home today is that inadequate bony reconstruction is the commonest cause of enophthalmos. Very less often the soft tissue scarring. More often it is the bony inadequate reconstruction. Also, secondary reconstructions, whenever we plan, a 3D planning and navigation guided surgery helps us to achieve that perfection that we want. So now another patient who has had surgery in the past, residual enophthalmos. He has lag of thalamus and he was referred for facial palsitomy. But what we found is that the zygoma was not in place, the floor fracture was also not repaired. So we pre-contoured implants on a mirrored skull model. That is a very useful technique if you don't have navigation. But we did use navigation also in this patient. Post-operatively, the lag of thalamus get corrected. So enophthalmos is a very important cause of lag of thalamus, and post-operatively you can see that the enophthalmos as well as the lag of thalamus gets corrected well. So the lesson here is that the enophthalmos can cause lag of thalamus. Zygomatic arch reconstruction is important to correct the facial width, and preauricular incision is a useful technique which you saw that I used in that patient. It is good to expose this distal end of the zygomatic arch, and pre-contouring on mirrored skull model is an option to achieve symmetry. Now another patient, now here the body of the zygoma is comminuted, so it is very difficult to move the zygoma, and even if you move it in place, you're not going to get that anterior projection adequately. So in these patients we use only implants, and we use PEEK material here, that is polyether ether ketone, for the rim, and I have used titanium mesh for the floor and the medial wall, and this is the Medpur coated titanium. So when you have a complex fracture like this where patient has undergone multiple surgeries in the past, it is a good idea to have a smooth surface for reconstruction so that you don't have orbital adherence, and therefore I preferred a Medpur coated implant in this patient. So Medpur coated titanium is a good option in these kind of complex orbital reconstructions. PEEK is a good material for the rim, and only implant when the body of zygoma is comminuted. There's no point moving the zygoma in these cases because the body is comminuted. Now another patient, floor, medial wall, very large defect. So here you need a patient-specific implant. Your pre-contoured implants are not going to work, and the enophthalmos, very gross, also can get adequately corrected. I'm finding it so difficult to catch up with this. Another patient had 4 surgeries in the past, and she still had enophthalmos. Again, you need a patient-specific implant to correct this enophthalmos. Another patient, he is using a prosthetic eye on the right side. The socket is inferiorly displaced, so I have designed a PSI. You can split the PSI in several components so that you can have an ease of insertion, like you can see in this patient, 3 components, and the socket moves superiorly then, and you can get a good correction. Another very, very gross enophthalmos patient, when you design a PSI, it is a good idea to get that kind of a small projection here on the intact bone, which keeps it from moving in the horizontal plane. And that is one small tip that I like to give today, that the PSI design is very, very important. Like you see this gross enophthalmos. You can even design cutting guides, like you can see here, the purple is the cutting guide. You put the guide first, and all the bone beneath that you can cut. Same way, the zygomatic arch, I have designed cutting guides which guide you, and you can achieve symmetry in the post-op period. This was a recent case, and this was the intra-op correction. You can see more than 8 or 9 millimeter of enophthalmos that he had preoperatively gets corrected beautifully when you design the PSI well. Another patient, now here he doesn't have enophthalmos, but I wanted to show you that when you want to move the zygoma when the body is intact, like in this patient, you can design cutting guides so that you know exactly how much of zygoma you have to move. You can get a position guide also, like this is the position guide, and then design the patient-specific implant in such a way that your movement is absolutely accurate and symmetrical, and then you can get very good result after the lower lid correction. You can also have positional guides like this. So when you're putting this floor implant, if you have this positional guide and you pre-drill these holes, if those holes coincide with your mesh, you know that you are accurate. So this was the cutting guides that I was talking about, and this was the small extension that I usually use in all these kind of complex cases to design my implants. And I also design the direction in which the screw will go preoperatively. So I tell my designer in which approach I'm going to use, like transconjunctival or transcutaneous, so that the direction of the arrow, the direction of the screw also can be decided preoperatively. Now sometimes in these patients the plane of dissection is very difficult. So if you see this patient, the orbit and the sinus tissue is all like one big fibrotic tissue here. So exactly which plane you should dissect becomes very difficult. It's a good idea to put traction sutures on that inferior rectus muscle, and then retract all the orbital tissue superiorly, go as inferior as possible, because whatever soft tissue you can get into the orbit only helps you to correct the orbital volume, and that is a very nice tip. So always stack the recti muscles whenever you have this kind of a very gross enophthalmos. Now what we do is we overlay soft tissue on the bone whenever we are mirroring, so that we can pre-place holes for the lateral canthal fixation. And that is what I have shown here. These holes which are pre-placed, they help you to place the lateral canthals in the right place. Now there is so much of talk going on about orbital fat or fat injection being used for enophthalmos. But what we have to remember, can you play that video please? What we have to remember is that these orbits are not pliable. They are very, very fibrotic, and also many of them have vision, and therefore injecting this fat in the retrobulbar area, which is already very scarred, the fat survival is unpredictable, and also there is a high risk of loss of vision, because the vascularity is also compromised in these patients because they have had previous surgeries. Now the last patient, this patient had had 4 or 5 surgeries in the past. She had a gross telecanthus, enophthalmos, and a naso-orbito-ethmoid fracture. She already had a transnasal wire. We have redone the transnasal wiring and the orbital reconstruction and a DCR and a strabismus surgery. And she sent me this whole set of pictures from her house celebrating festivals in India. So these patients, it's not only about anatomical reconstruction, it is also a social and psychological rehabilitation for these patients. Thank you very much.
Our next speaker is Yuri Billick. He'll be talking about reconstruction after trauma, tumor excision, ethical issues in some pre-plant cases.
Thanks, Bob, and thanks, Luigi, for the invitation. What I'd like to talk about today is the ethics of free flaps and some of the issues we have with that, and I have no disclosures. So a couple of ethical considerations for the audience. The first thing is, does the technical ability to do a surgical procedure justify its use in everyone? And the second issue is, at what point does a non-surgical modality, even though it may not be worked out in its details, supplant the use of that surgery? So a wide resection of the orbit, what I call exoneration plus, would include the orbit plus a lot of surrounding tissue. And that leads to not only a lot of perioperative risk, but also to a significant psychological issue with facial deformity. So we all know that when we do exoneration plus, we actually expose some critical structures, the dura, the brain, to the environment, but also to paranasal sinuses, which increases the risk of infection. So in the past, a lot of these large excisions, or large lesions, I should say, were deemed inoperable because we just didn't have the technology to fix the defect in a safe way. Here, for example, is a woman who has a recurrent malignant grade 3 meningioma, and this is incurable. She's failed everything, but she's in a lot of pain, has a blind, painful eye, wants palliation, and here is the MRI showing you how large the tumor is. Here is the defect. You can see the specimen containing the eye and the ear. And this can't just be closed with conventional technique. So a free flap was performed, and here she is 10 days out. Pain is gone, and she's quite happy, and her quality of life improved for the remaining 1 year that she had before she succumbed to her disease. So in this case, the free flap was a very good option for this patient. The great thing about a microvascular free flap, for those who are unaware of this, is it allows you to cover a large and very deep defect by taking skin, dermis, muscle, bone, what have you, that's fed by one artery and drained by one vein. And that really provides a lot of good protection for critical structures, like I mentioned, dura and brain. Not only that, but the instant vascularity to that tissue allows you to proceed with earlier chemoradiation. You don't have to wait for that tissue to be vascularized. So here are some of the angiosome maps. And you can see that each of these areas is supplied by one artery and drained by one vein. And here just happen to be 3 of the ones that we use very frequently. And for example, if you use the radial forearm flap, you can also include bone in your graft, which is sometimes very helpfral for cranial orbital reconstruction. Here's an example where it's really, really helpful. A neglected basal cell carcinoma. Here is the defect. That's a big defect. Here is the latissimus dorsi flap that the ENT free flap team harvested, and you can see the one artery and the one vein that's feeding and draining this flap. Here she is post-op. With some camouflage, it looks pretty good. But notice in the scans how vascular this lesion is, vascular the flap is, I should say, which allows for any adjunctive therapy. And also, on the axial image on the right, how well covered the dura and the brain are with this free flap. I just wanted to show you, I think this is important, our sort of distribution of pathology for exoneration plus, those extended exonerations that we had to do at Jefferson and at Wills Eye. And it's important to, and other studies have also shown this, it's important to point out that about half of the exonerations we did at Wills were for cutaneous orbital spread of a cutaneous malignancy. About half. And about a third of those were squamous cell carcinoma. And I'm going to get back to that in just a few minutes to talk about other options. The problem with these free flaps is that it's a major, major surgery. The anesthesia time, 11 hours, long hospital stays, long rehabilitation, and you very often have to plan for secondary surgeries both to the recipient bed and to the donor site. There are complications. Again, a great surgery with significant complications to the recipient bed, to the donor site, and systemically. And I'll show you some of those cases. Here, for example, is a patient with exposed dura and brain. And here he is afterwards. That flap looks great, but the flap is large and is putting a mass effect on the brain with midline shift. Fortunately, he didn't herniate, but he didn't wake up for 3 days. And he finally woke up once the edema subsided. Another patient, a loss to follow, exonerated previously for a basal cell that now recurred in the other eye. The eye is blind. Another free flap team takes him to exonerate him, and he's doing well during surgery, but post-operatively has focal neurologic deficits. You can see the flap up above. You can also see the stroke down below. And what happened during the surgery is that one of the vessels retracted back into the vein, and while they were placing the free flap for hours, he was bleeding actively into his brain. He needed a hemicraniectomy for the edema. Here he is afterwards, not a good result. And this is a problem with these large, long surgeries. Another patient with a lot of systemic disease, diabetes, obesity, heart trouble, and so forth. We actually recommended against surgery, but another team decided to go ahead, and he had a hemorrhagic stroke post-operatively, probably because of his comorbidities. And then finally, a case I just saw 2 weeks ago, a sinonasal tumor that was removed by ENT, and for whatever reason, they took out both medial orbital walls. Here's the post-op scan the day after the surgery. They said it looked good. We were called 2 days later for chemosis, and what was missed on that post-op scan is the mass effect you can see right there on the globe, on the orbit, and she's NLP on that side. Fortunately, the vision was okay on the other side. So there are relative contraindications to free flaps, but one of the best contraindications now, which I'll talk very quickly about, is other treatment options. So to move things along, everybody knows that perineural invasion of squamous cell carcinoma is a deceptive disease. It usually presents very late in the course. Here, for example, is a patient referred for Bell's palsy, sensory changes, and so forth. It took a year before he got to us, and he's got perineural spread into the orbit, cavernous sinus, and into the temporal lobe. And this is an old case, and what we did for him was what we did for everybody back then. We did payload exoneration with post-op chemoradiation. We probably would not do that now. So I'm going to just move things along to stay on time, but targeted therapies, and Vita mentioned these, are becoming a huge option for a lot of these patients. So the problem with targeted therapies is that basal cell, squamous cell, and other tumors have different pathways. So it's not sort of a mix and match thing. But what we do have now is a lot of options. The problem with some of these therapies is that, number one, they peter out. Their action may lose efficacy over time. And a lot of these medications have significant side effects. So here, for example, are some of the side effects. The patient on your right couldn't eat for 2 weeks because the mucosa in her mouth had melted away from the therapy, and the therapy had to be stopped. I'm just going to take a minute or two to talk about checkpoint inhibitors because I think this is very, very important. And if the audience is unaware, here's sort of a little primer on what this does. So you see up above an antigen-presenting cell. Let's just assume it's a cancer cell. Well, the cancer cell has antigens, and a T cell finds these antigens and realizes this is something bad. This does not belong in the body, and unleashes the immune system to attack this. The problem with a lot of cancer cells is they've camouflaged themselves with checkpoints. And when those checkpoints latch onto the T cell, it basically tells the T cell, I am normal tissue, there's nothing wrong here, move along. And the immune system just bypasses the cancer cell. And what checkpoint inhibitors do is it's an antibody that latches onto that checkpoint, blocks it, and allows the T cell to activate. And we have now a lot of these inhibitors available, and in the last few minutes, I'm going to talk about some of these. So the FDA has approved about 9 of these now, and that is getting larger and larger. And here's some of the data on this. So the first one that was used was Pembro, and it was okay for squamous cell carcinoma, but the one that we really, really like now is cemiplimab. And you can see some of these studies. This is a slide from David Verity showing the purple is good. The purple is either stabilization or improvement of disease in one large study. A more recent study from OPRS, small, only 11 patients, but look at that result. Now again, we don't say it's a cure. These patients have responded to therapy, but they're not necessarily cured. And one of the problems here is the duration of follow-up is, not that long. Let me just show you a case though. A 70-year-old squamous cell removed from the forehead, develops some numbness, and you can see it takes almost a year for her to get to us to make the correct diagnosis, and that's one of the problems with this disease. And here she is, and I want to point out that externally she looks perfectly normal. But she has the right symptoms. We do a biopsy. It confirms the diagnosis. Here's her MRI showing disease. Here's her PET scan, very high SUV. It's very metabolically active, and we recommend exoneration. She flat out refuses to say, I am not having disfiguring surgery. So we put her in a cemiplimab trial. She gets the first dose, and a week later calls me and says, I think I have an infection in my eye. It's very swollen and very red. I told her to come in, and this is what she looks like. And I tell her, this is great, because the immune system is attacking your cancer. And this is what you want to see with the PD-1 inhibitor. And here she is after the first dose. PET scan is clean. We follow her very closely. I re-biopsy her. I find no disease. And I just saw her last month. She's now 3 years out with no evidence of recurrence. So what does this mean to us? This is what it means. This is just a recent study from Bascom Palmer. We've noticed the same thing at Wills Eye, where our exoneration numbers have dramatically dropped, in this case 39%, because of the ability to control the disease. So I'm just going to go past the side effects, and there are numerous side effects, to the last slide. So in conclusion, free flaps are a great surgery, but they have risks, and they're not the right thing for all patients. There are a lot of psychological side effects from this, and a lot of systemic side effects from this. The advent of targeted therapy is playing an exceedingly important role nowadays. Is it primary therapy? Maybe. Is it adjunctive therapy to shrink the tumor? Yes. The problem with this is another ethical concern with targeted therapy. Are we using it too soon and burning a bridge that we might want to save later when a tumor occurs? I don't have an answer for that. And I just wanted to take a minute to say a few words about Daniel. He was a dear friend, and I miss him terribly. And Philadelphia is not the kindest city in the world, but we have a term for somebody that you really respect. And when somebody asks, well, how's this person? The best thing a Philadelphia could say is, well, he's a really good guy. And Daniel will always be, for me, a really good guy. Here he is at our last meeting, pretending to be a medieval monk and sitting in a grove of olive and fig trees. And I miss him terribly, but I'm pretty sure that he's upstairs with St. Peter taking very detailed notes about this meeting. So thank you for everything, Dan. Thank you.
We have our series of 5-minute or 4-minute rapid fire cases, the first of which will be Dr. Suarez. Multiple cameras, venous malformations, and the same orbit diagnosis and management of an atypical case.
Good morning, everyone. We are going to start. Sometimes small asymmetry can hide an unexpected orbital finding. This is one of those cases. He's David, he is 42 years old, and he came to consultation because he noticed progressive asymmetry of his eyes for about 6 months. He was otherwise healthy, without relevant medical history. He had no pain and no diplopia. On examination, visual acuity was 9/10 in both eyes, with normal color vision. Slit lamp examination was normal, and pupillary reflexes were normal too. We observed mild proptosis of the left eye with inferior displacement of the glove. Extraocular movements were full without restriction. And on palpation of the left orbit, we detected 2 firm and mobile masses, one on the superior eyelid crease, another in the inferotemporal quadrants. With this finding, we requested imaging studies. The CT scan revealed 2 well-defined and retroocular masses in the left orbit, measuring around 24 and 20 millimeters. The MRI clearly showed the 2 lesions, one in the superior orbit, another in the inferior orbit. And both lesions were iso-intense in T1 and hyper-intense in T2, and stir sequence. Considering the clinical and imaging finding, we decided to perform surgery, so a transconjunctival approach was used to remove the inferior lesion, and a lateral orbitotomy was performed to remove the superior lesion. Both tumors were completely removed without complications. The histopathology confirmed a double cavernous venous malformation in the orbit without continuity between the 2 lesions. The patient recovered well after surgery. The visual acuity remained at 9/10 in both eyes, with full extraocular movement and normal pupillary reflexes. Here we can see the result after surgery with a good symmetry between both eyes. And this case shows that cavernous venous malformation may present as a multiple lesion within the same orbit and can be safely treated. Thank you very much.
Right on time. We're going to ask our next 2 speakers, one who's on right and the one that would be Dr. Suzanne Requirements. Oh, I'm sorry, we just had that. I apologize. Dr. Dominguez Salgado, who caused this growth, neoplasia versus infection, and then our subsequent speaker, Dr. Fabio, could be prepared on the other side there.
Good morning, you all. We're going to start this morning with another case report. It comes to our hospital in Mexico City, and the authors declared there are no conflicts of interest. Well, we have a 26-year-old male patient who presented to the ER with a chief complaint of edema and erythema in the lower right eyelid for 15 days associated with gastroenteritis, and that was currently treated with some antibiotic therapy. The past medical story of the patient referred an episode of herpes zoster 1 year before without any kind of sequel. The ophthalmic examination revealed a visual acuity of 20/20 for both eyes, and the slit lamp and fundus examination was unremarkable for both eyes. But now we have a really great surprise, because this is the patient, and as we can see in the front photograph and the 45-degree photograph, and the presence of a well-defined violet Fermi rubbery mass 4 by 5 centimeters with induration of 1 centimeter 360 around. That's why we perform a CT scan. In this CT scan, we can see that mass that was completely homogeneous, solid in the perceptual space, invading the muscles, but doesn't have any complaint in bony structures. Our patient, in further interrogation, revealed an unintended 20 kilograms weight loss, and also in a complete blood count by cytopenia. Our patient lost follow-up for 10 days and returned to the appointment with a decrease in the size of the lesion, because he started a treatment with oral prednisone by another physician. Something important to say also is that the conjunctiva has this salmon pink fleshy patch on the temporal side. We perform a biopsy, transcutaneous biopsy, having a result of dense infiltrate and numerous mitosis with really high positive CD45 and CD3, having a result of T-cell lymphoma. Talking about these lymphomas, they constitute a group of malignant lymphoproliferative diseases involving the lacrimal gland, the conjunctiva, and most of them are not Hodgkin lymphoma. Almost 80% of them from B cells and 14% from T cells. A primary is really rare, and it's most present in people in elderly age, 50 to 60 years, and the majority of them have a systemic course at the time of ophthalmological clinic. Some authors suggest that there is a high correlation between lymphotropic virus presenting as gastroenteritis first. Histological subtype is really important because it gives us some prognosis and also performing an immunochemistry. For diagnosis, imaging, CT scan is the first step, and also we can perform a blood test, and for treatment, the surgery, that's only biopsy for necessary, but it's not the treatment. The treatment is a completely multidisciplinary ophthalmology, hematology, and oncology, chemotherapy, and radiotherapy. Our patient received radiotherapy in another institution. Finally, to wrap everything up, these lymphomas are rare, but the ocular manifestations are at the time of systemic disease. They're aggressive in young patients and doesn't have a really good prognosis. Thank you very much, and I'm open to any question.
Thank you. And now we'll have Dr. Barrio, take it or leave it, management of residual and recurrent pleomorphic adenoma of the lacrimal gland.
Good morning, everyone. Thank you for the opportunity of sharing this challenging case of recurrent and residual pleomorphic adenoma of the lacrimal gland. So, this patient was first seen in our appointment in December of 2024 with an history of a previously operated pleomorphic adenoma of the right lacrimal gland. She was being followed up with serial MRIs, and in our first appointment, she had a mild inframedial dystopia of the right eye with no other clinical signs. To fully understand this case, we went back and took a look at the scans that the previous surgeon had operated on, and we can see a hyperenhancing mass in 2020 on the right orbit, in the supratemporal quadrant of the right orbit. And in follow-up scans after the first surgery, we can see that there's a continuous growth of this lesion. It's very important to look at the scans and to not trust blindly the radiological report, because when they describe a millimetric growth, it is in fact a significant growth. So we are here with this patient. What should we do? Should we take it? Should we leave it? Should we observe it? we decided to take the lesion out, and it was a very posterior lesion with very adherent to surrounding structures with no clear cleavage plane, which led to an incomplete excision in 2025 from our team. This was our clinical examination at the time. And what should we do next? We took a look at the literature, we saw what was described, and in fact, there's not much described in residual pleomorphic adenoma of the lacrimal gland. The literature mainly focuses on malignant transformation. There is no clear description on what kind of biopsy should we do. But there are some reports that use adjuvant treatment, especially in recurrent or residual pleomorphic adenoma of the salivary glands. So, what should we do? The patient was discussed in a multidisciplinary board, and due to her age and the risk of further recurrence and malignant transformation, the team decided to go ahead with adjuvant treatment with proton therapy, which was led between November and December of 2025. Here are her scans before the proton therapy. We can see a hyper-enhancing image still that may be due to residual scarring or residual lesion. And here are scans after the proton therapy. We can see that despite different imaging techniques, the exams are very comparable. So this is our patient now. Take-home message from this case. This is a very difficult and type of tumor to treat and to follow. There is not much literature on it, and it's a challenging case to manage. The role of adjuvant radiotherapy and proton therapy is yet to be proven in these kinds of cases, but it's something that we need to follow. Thank you so much. Obrigada.
Excellent case. And now, Roberto will be talking about Triton and Pandora's box.
Buenos días. Bueno, voy a hablar de Tritón y la caja de Pandora. En la mitología griega, Tritón es el hijo de Poseidón, el dios mensajero de las profundidades marinas. Pandora fue la primera mujer mortal creada por orden de Zeus y tenía como atributos la belleza, la persuasión, pero también la curiosidad. Y Zeus la casó con Epimeteo y le regaló una vasija que se traduce como caja, que nunca debería abrir. Biológicamente, los tritones son salamandras que pasan la mayor parte de su vida en el agua, que son muy comunes en el sur de España. Popularmente, la caja de Pandora es encontrarse con una sorpresa o algo inesperado. Esta es el primer caso es una mujer de 59 años con una exoftalmía del ojo derecho de 6 meses de evolución y que tenía 2 milímetros de exoftalmos. Dolor ocular, sin oftalmoplegia ni compromiso visual. Se solicitó la tomografía computada de órbita, donde se ve un tumor intraconal, que lo pueden ver en el corte parasagital y en el coronal, que en general uno piensa en un tumor, un edema cavernoso. Pero la histopatología y la inmunohistoquímica mostraron algo bastante diferente y la cirugía era una masa friable, violácea, que no parecía un angema cavernoso, y en las muestras se observan abundantes fibras de tejido muscular esquelético desorganizado. Esto asociado a una profusa red de tejido nervioso con áreas de tejido fibrodiposo y marcada congestión vascular. Este es el posoperatorio. La paciente quedó con una leve tosis y una limitación en la elevación, pero digamos no hubo una recidiva del tumor. Y el segundo caso es un paciente masculino de 16 años que tenía una exoftalmía del ojo izquierdo de 4 meses de evolución y con una leve limitación de la aducción. Tenía una tumoración a nivel interno y se procedió a la resección de la misma, observándose la misma patología y la inmunohistoquímica. Como ven, entre 1980 y 2025 tenemos 2.551 casos quirúrgicos, de los cuales la mayoría son tumores, y es la primera vez que llegamos a un diagnóstico de tumor de tritón, y en este caso son dos, que son tumores compuestos por elementos neurales y musculoesqueléticos. Su nombre deriva del anfibio salamandra, donde se cree que un nervio puede inducir la regeneración del músculo esquelético. Son tumores muy poco frecuentes, en general asociados a grandes nervios y en infantes pequeños, ciático y braquial. Son amartomas de origen neuroectodérmico, o sea que forman parte de los tejidos que están dentro de la zona. Mesenquimal y raramente se presentan en adultos. La localización orbitaria es excepcional y suelen ser del tipo no agresivo. Y en general se los confunde por sus síntomas e imágenes con otros tumores más frecuentes como son los angiomas cavernosos o los schwannomas. Las conclusiones es que las cosas no siempre son lo que parecen. La órbita sigue siendo una caja de Pandora. La clínica y los estudios por imágenes nos permiten un diagnóstico presuntivo y una planificación para mejorar un abordaje quirúrgico. La experiencia es fundamental y la última palabra la tiene el patólogo. Estos son dos casos, no hay en la literatura, solo hay case report de un solo caso, y esta sería la primera vez que hay dos casos de órbita juntos. Bueno, muchas gracias por su atención.
Thank you. Our next speaker is Ganga Sundar, the challenge of apical orbital lesions, a transnasal approach.
Buenos dias. I'm here to share a little experience on more challenging tumors, including a few confessions over here, but not too bad after all. So this is a 51-year-old, young by my standards. Bare light perception, she found out when she lost her husband, and she's crying, she rubbed the other eye, and suddenly realized she couldn't see over the eye. You can see that she had a 3 mm proptosis with a gross intervertebral pupillary defect. And that's what the optic nerve looks like. Pale optic nerve, so it looks like a chronic pathology of some kind. Imaging shows a beautiful apical orbital tumor right at the apex, where normally we wonder, should I go for it, should I not go for it, or should I treat it some other way? So do you observe, because she's already lost her vision, hardly any minimum proptosis? Should you do a craniotomy approach, a transconjunctival approach all the way to the apex of the orbit? Or should you radiate, as we discussed on day one? Here's another man who was actually treated for quote-unquote optic neuritis by a neuro-ophthalmologist with steroids with no visual improvement. The second neuro-ophthalmologist saw the patient and found there was some pathology behind, but they said that because of the poor vision, minimum proptosis, leave the patient alone, and the patient self-referred himself to us. And once again, you can see a nice apical orbital lesion right over there. Bang, that's where I'm scared of going in to take this eye out, or the surgical lesion out. So once again, similar lesions, I have a bunch of them actually, but just 2 for today. Observe, do you do a transcranial approach and put all the blame on the neurosurgeon, do a transconjunctival medial orbitotomy, go all the way there and then knock out a little bit of the optic nerve, or you do radiate. That's where we think outside the box. And yesterday we had a beautiful talk by Eduardo Rubin talking about sinonasal approaches to orbital tumors. If we can play this video here, click on the video. So we did just that, a transnasal, transeptal, forehand approach to the medial wall of the orbit. Can we play the video, please? Can just click on the video, because I'm not sure how to click on this video. AV? AV team there? Roberto? He's gone. Can you click on the video, please? Yeah, perfect. So as a transnasal approach, we cut to the chase, go to the medial wall of the orbit, much like an orbital decompression. Let's say periosteum, we incise, like we do an orbital decompression. Strip off the periosteum right over there. And when you strip off the periosteum, lo and behold, you're going to find the medial rectus muscle. And that's the periosteum coming off, orbital fat, which is a friend in the orbit. At the same time, can be a pain. You can see the medial rectus, and knowing where the location is, go dissect bluntly below the inferior medial rectus. We are ballotting the eye from the front. Literally, there are 4 hands through the nose, through the septum actually, facilitating delivery of the tumor. And the tumor is inherently adherent to a lot of structures, including some important nerves there, whose names I don't really know there. So you have to do sharp dissection on the intracornal side of this dissection of this tumor, and slowly and progressively taking the tumor out. And finally, transnasal delivery of the tumor, as you can see in the bottom right here. So nothing as gratifying as taking it out intact, and especially with a cavernous venous malformation, which delivers itself mostly well, but still are adherent, and finally take it out through the nose. But what is important is, we oftentimes forget to reconstruct the orbit when we do these transnasal excisions. So we put a bioresorbable implant in the mucosal graft. So this is a sequential picture of the same case as well, and the schwannoma, the second case itself, which is taken out piecemeal and go ahead and reconstructed. So these are patients who now actually have an ability to recover almost soon after procedures and gradually improve. So coming to discussion in the last 10-20 seconds is apical orbital tumors. Should you take it out or not? Keep in mind that yes, some of them can really be removed, but more importantly, don't be the orbital surgeon who does not reconstruct the orbit, because sino-orbital adhesions has been a major cause of morbidity and apical orbital lesions. Thank you very much for your kind attention.
D'Amelio, management of exposed endoprosthesis with donor scleral patch.
Good morning. Thank you, Luigi. The management of the exposure of endoprothesis using donor scleral patch. Evisceration is a destructive procedure associated with both aesthetic and psychological rehabilitation. Unfortunately, in many cases over the years, we have seen exposure of endoscleral implants. Even today, many surgeons in case of endoprothesis exposure opt for its removal and often for an operation. This choice seems to be derived by the fear of infection complication in the photo and early exposure. The material used to make endoprothesis are hydroxyapatite, silicone, and PMMA. The risk factor to the endoprothesis exposure are multiple surgeries, conjunctival malacia, scleral malacia, diabetes, scleral suture not properly setted, endoprothesis too large, cosmetics, prosthesis, desutus. The scientific literature, and the procedure is very simple. Separate the conjunctiva from the sclera, remove and hold exposure sutures, check that the remaining sclera is not malacic, take a culture swab, clean and disinfect the surgical bed, then a caliper is used to measure the effect to be covered. Finally, the donor scleral piece is modeled, must exceed the margin of the defect by at least 2 millimeters. Particular case must be taken when placing the suture, which must be placed between the native sclera and the inner surface of the donor sclera, ensuring that they are completely covered and no longer visible. Only this precaution will protect use and the patients from any further recurrence. This is our experience: 3 hydroxyapatite explosion, 56 silicone bed explosion, no body complication in 2 casuistic. The surgery can be performed with peripulvar anesthesia. In some cases, sedation can be associated. Average duration in 13 minutes. Same day discharged with minimal post-operative discomfort. In 40 patients, we reapplied the previous removable cosmetic prosthesis. In 4 cases, you used a new cosmetic prosthesis and temporarily a conformer. Oral antibiotic for 5 days, a topical therapy for 3 weeks, cleansing of posterior periocular area, conjunctiva and cosmetic prosthesis, paracetamol as needed for the pain control. Always remove the prosthesis during the post-operatory check.
the next day at 7 days, 50 days, 21 days, and a month. In patients with hydroxyapatite implants, we performed one blood culture for 3 months. The images, the first case in the follow-up to 5 years. In our experience, the surgery technique has been proven and simply inexpensive, effective, and free for complication. It's possible to treat elderly and debilitated patient with a minimal invasive surgery. Thank you very much.
Thank you. And our final 4-minute presentations by Dr. Ardito, Psychological Impact of Ocular Loss and Multidisciplinary Management.
Good morning. Ocular loss represents not only a functional defect, but a complex psychosocial condition. As ophthalmologist and ocularist, in this presentation, I will briefly review the main psychological implications of ocular loss and the role of prosthetic rehabilitation. Ocular loss is a loss of a visible body structure. The eyes are the first feature we see when we look ourselves at the mirror, and the first feature others notice. For this reason, ocular loss has a strong impact in identity on social interaction. Patients with ocular loss may develop depression, anxiety, social avoidance, in addition other symptoms, as hostility and somatic complaints have been described. Beyond these conditions, patients frequently present with disturbances in body image, perceived as stigma, alterations of self-identity. They may develop hyperfocus on asymmetry and misread social cues, which reinforces psychological distress. Some patients develop adaptive denial mechanism. They lead for poor prosthesis care, irregular follow-up, and delayed consultation. In some cases, delayed initiation of prosthetic rehabilitation may reflect denial of ocular loss. Hostility has been identified as a prominent psychological response. It likely reflects cumulative stress related to functional disability, changes in appearance, and psychological burden. Like this patient I show here, this patient with microphthalmos, he has never used anything. At 23 years old, I treated him. I made the fornices, I expanded with pressure conformers, but finally with the prosthesis, he hated me. Somatic symptoms are also common. Patient may report headache or ocular discomfort attributed to the prosthesis, which may reflect underlying psychological distress. Phantom eye sensation has been described and may be associated with depressive symptoms. In the early stages, patient counseling is essential. Adaptation, both psychological and visual, occurs over time. Patients initially experience difficulty with deep perception and visual field, but most develop functional compensation. Prosthetic rehabilitation improves confidence and social interaction, with significant impact in emotional well-being. It is important to set realistic expectation in the first consultation. The goal is not absolutely symmetry, but natural, comfortable result. Long-term success depends on regular follow-up and appropriate prosthesis maintenance. Finally, I will show the two cases because some customized or this fantasy prosthesis in children helped me to some patients to improve the acceptance of the use of the prosthesis. Ultimately, our goal, we must remember, is not only rehabilitation, but long-term acceptance and confidence in the patient. Thank you.
Thank you. So we now have time for some questions. I know, again, we're going to ask you to try and text those in on the app. we already talked to Alberto to start to Augusto to get things started at the first session. And one of our panelists, I think, had a question for Dr. Graue. Is that correct? Yes.
I used to when I was working at the university.
It's just a curiosity. I was wondering about the type of material used for the simulation of the soft tissue, because it's one of the most complicated parts to perform, not only the bony decompression, but also the management of the soft tissue. So, to teach, I mean.
Hello? So I think these kind of models should be done in a cadaveric model, right? That would be like the closest to the tissue that we treat. And a cadaver conserved in cold, how do you call this? The fresh frozen cadaver, yeah, sorry. So in this video we used just clay, the one that the small kids used to play. But I think that the better way to do it is with a fresh frozen cadaver.
Thank you. We have Ramon.
This is one question for Vita, Smiley. What is your approach in local recurrences? Do you retreat with radiotherapy? So what is your approach in local recurrences? Local recurrences. Recurrences, I'm sorry. Yes.
Yes, of course. So local, but I had so many questions for the other speakers, that's what's on my mind. But anyway, so local recurrence after eye-sparing surgery, I assume that's what you're asking, but we can talk about exenteration as well. So local recurrence after eye-sparing surgery followed by radiation therapy. So it depends on how big the recurrence is and where, right? So I think that most often, in the case of a local recurrence after previous good eye-sparing surgery and radiation would lead to an exenteration. That's how I counsel my patients. So we're going to do this way with eye-sparing, but if it recurs over time, likely you will have an exenteration. Simply because it's difficult to then re-radiate for a second time. It can be done, it's not impossible. You can do it stereotactic after previous protons, but it's not very easy to do, and it has a lot of toxicity. So if a patient recurs after an exenteration, which can happen, usually, in my experience, it's in the perineural pattern, meaning it's cutaneous recurrences along the nerves, and those, again, you would do surgery and radiation for. The eye's already gone, but you need to do additional treatments. I have a couple questions for the other speakers, but I'll go sit down and when the time is up.
No, don't sit down. Stay. Do you have any experience with brachytherapy and external radiotherapy together?
Brachytherapy, so plaques and external beam together, was that the question? For what disease? For which disease? For adenocytic carcinoma. So, I mean, to my knowledge, the only experience with brachytherapy, which is basically plaque radiotherapy, is it's anecdotal for a few cases, at least to my knowledge. I think Jerry Shields, my dear friend and colleague, bless his soul, he used to talk about a couple cases where he would put a reverse plaque in the orbit. The issue with that, the theoretical issue with that, is that for adenocytic carcinoma, you really want to treat regionally. Brachytherapy is incredibly focused for the area that you put the plaque in contact with. So it may not, it may have worked in the couple of cases we've heard about, but I would say that for the majority of cancers, for the majority of cases, that's probably not adequate. That's my humble opinion. Yes, Yes, I mean, I think, it depends on the stage of presentation, and if it worked for your patient, wonderful. But I think that, if we want to come up with paradigms that work for the majority of cases, brachytherapy may have limited use.
Yeah. Well, Lita, I was also, hello, I'm here, sorry, behind. I was also thinking to ask you something more about radiotherapy. We have had quite a large experience in Amsterdam with brachy, not plug, but stepping source brachytherapy. That is extremely useful when we have infiltration into the tissue, because we can put our catheter into the tissue, and depending on the timing we leave the stepping source in a given place, we can shape a vectorial, field of irradiation. And we can shape our isodosis curve. Nevertheless, we have had several recurrences. Since when I'm using first proton beam irradiation, following careful dissection, and nowadays proton beam together with carbon ion irradiation therapy. So first proton beam, and the last 8 application, carbon X, carbon ion, we have had practically never ever local recurrence. The survival rate doesn't change, because most of the time when we operate, metastases have already left. Okay, and of course, mainly the adenoid cystic, we are speaking about that, is spreading through a neuro spread, but it gives also lymphatic metastasis, and that is
hematogenous metastasis,
yes,
bony and lung.
Yeah, exactly, and then the lung are always involved. I have had several cases at about 6 years, 5 to 6 years after surgery, never local recurrence, but lung metastasis at that timing. Unfortunately, we cannot do that much. He is biologically not aggressive, but he is going on his route. The carcinoma that very often is confused with adenoid cystic, unfortunately, we don't have any possibility of treatment. Do you have any different data on that? Because anytime we have adenoid cystic, we intervene. With a carcinoma, we have to, let's say, block hand.
So are you referring to pleomorphic X carcinomas, adenocarcinomas?
Or transformation from,
pleomorphic. Yeah.
From pleomorphic, or let's say primary, let's say discover carcinoma of the lacrimal gland.
So the adenocystic carcinoma is the most common. The next most common is probably adenocarcinoma in the background of pleomorphic X. And adenocarcinomas, a group of them will have HER2 receptors, and that's an opportunity for HER2 receptor antagonists, such as Herceptin or the antibody drug conjugates. So it's actually, but some of them are not HER2 positive. But the treatment should be surgery followed by radiation. But if they're particularly large, you can also do chemoreduction. So the treatment approach should be very much the same. But I had a question for the recurrent pleomorphic adenoma presentation, the multifocal pleomorphic adenoma. I think it's relevant to this discussion. If I understood correctly, you surgically removed the multifocal recurrence that we saw in imaging, and I think histology showed benign. And I want to say that's actually really common, and I think you alluded to that, meaning most often we don't have malignant transformation, even though the literature really hypes the malignant transformation risk, which exists, but in fact, the majority of cases of recurrence of pleomorphic adenoma are quite multifocal. You showed sort of a non-contiguous recurrence, almost, that was incomplete excision, really. Plus, it happened so early in the course. That was incomplete excision. But even with the seemingly complete excision, you can get multifocal recurrences late in the game, like even beyond 5 years. And they're almost like little pearls. I published this in a paper, I don't know, people don't find my papers very often. but if you look that up, you'll see that the majority of those cases are benign. And at least we would not radiate in a situation like that, because the toxicity of radiation is significant. For cancer, it makes sense, for a benign lesion, but they're very challenging. This is why a pleomorphic adenoma, or let's say a round lesion, because we don't know, it could also be adenocystic, really should be removed intact if possible, but still you can get multifocal recurrences, and that's a challenging case. We at least would not radiate. I would not radiate that case.
Can I make a comment?
I was going actually to discuss the case with you later because
that was your case.
That's my case.
Then it was done perfectly.
But the thing is, that's why we wanted to bring it here and discuss with everyone, all the experts on orbital surgery, because this is a very young patient. This was discussed in more than one oncology hospital. They'd have quite a good experience with salivary glands tumors. And so the thing is, due to there is no much literature in this specific cases, what to do next. This is a young patient, very young patient, with a residual lesion that most probably will recur. There's a high chance of recurring, benign, but that perhaps later, with all the benign recurrences, there is the risk. And so we didn't want to do radiotherapy. That's what we have available in Portugal. And that's why we discussed the possibility of doing protons.
But protons is radiation.
Yes, but
it's every bit toxic.
Yeah.
Just for the sake of discussion, proton radiotherapy, because of the Bragg-Peak component of it, it spares the brain structures. It does not spare the eye structures. So you have equal amount risk of radiation retinopathy, optic neuropathy. All the cases that I showed were protons. And you saw that we've published exactly how often you get radiation retinopathy, optic neuropathy. So it doesn't, anyway, there's no right or wrong, but I have several patients I'm still following with benign multifocal pleomorphic adenoma recurrence, and I know that they will have additional recurrences in the future. It's a question of when will you intervene with more surgery, and you want to time that carefully, because in their lifetime, there will be more. Your patient will have more, I hope not, but they might, but they also have radiation toxicity on top of that.
No, I totally agree, but that's the thing. There's no literature in lacrimal gland pleomorphic adenoma. There is in salivary gland.
But you didn't find my paper. You must look it up.
Oh, then I will look it up. Sure. But I think it's still a very interesting topic to see if there is a place for this or not.
The big difference is salivary gland, you're causing dry mouth. In the eye, big deal, yeah. I don't know time, but I have some other questions too. If there's time, I will.
Yeah, I think we got another 5 minutes. Yes, I think we do. We have to.
Come on.
I had a comment for your presentation regarding PD-1 inhibitors. Just for the audience, cemiplimab is wonderful, and it was marketed specifically for squamous cell carcinoma, but all of the PD-1 inhibitors pretty much work the same way, including Keytruda, that are in fact FDA approved for squamous cell carcinoma. And squamous cell carcinoma with perineural spread, which is the case as you showed, is a really wonderful indication, as you highlighted. We've published at least 10 cases, others have, but the one thing is that you need to continue with the treatments for at least a year or two for it to really hold. Because you mentioned sort of early relapses. That might be because it just the duration of treatment. And it spares, again, radiation and all of these toxicities. It's a really, really big advance. And your free flap comments, I tend to agree with, but if selected appropriately, free flaps are, yeah, I mean, as you know, there's a place for them, but just, I agree, if you have it hammered doesn't mean you have to, if you have, there's a nail in a hammer. Do you have any other thoughts on your exenteration comment?
No, I agree 100%. Free flaps are wonderful, but again, it's the hammer and nail issue. With cemiplimab, we've seen sort of both things, and our oncologists do treat it for a year or more. The question that no one can answer is, well, when do you stop? I think they kind of just make it up, to be honest with you. They do it for a year and see what happens. And the other issue is we don't really know if it's disease control or if it's curative. Lady's 3 years out, she's doing fine, but not everyone responds that way. Yeah.
But for radiation-treated cases, same deal. It was palliative anyway.
It's when it works, it is absolutely amazing. Yeah. But it doesn't always work.
So, Peter, I might add one other question and comment for you. The ones that I've seen of recurrent pleomorphic adenomas, generally it's in the setting of having known rupture at the time of surgery. So, fortunately, that hasn't happened to me yet, but I'm not done working, so it still could. So what I've done is I have them have some super glue in the room, and if this happens, I would plan to immediately wall off. I think what happens, people want to irrigate it, and when they irrigate it, they just spread it everywhere. Because I've seen the same things you've talked about. You have, 20 lesions, and they're all in the temporal fossa and just everywhere. So I would just caution, if that happens to you, don't irrigate it. I would glue it off, and then if I were going to irrigate with anything, I'd probably irrigate with alcohol. But
yeah.
I hope it didn't happen.
Yeah, it's an interesting observation, or glue, or perhaps a wider excision if you really see that it broke during the case. But there are cases where surgeon shows you that the nice round thing they removed 5 years prior, and then it just is multiple. And this thing about salivary gland, head and neck surgeons are very familiar with this multifocal pattern. It happens usually just right along their incision line. And but in the lacrimal gland literature, we're not as familiar with this sort of almost like pearl-like, multitudes of little cases, little lesions. This pattern is very well known for salivary gland pleomorphic adenoma, and I think that's what's happening in the orbit too. But yeah, any trick to do wider excision or perhaps glue.
And I think when you follow them with MRs, if you see any lesion start to rapidly expand, that's what you would go after, I presume.
Yes, in the situation, I have 5 cases like this that I'm really carefully following. I have operated all of them. They have been benign, and now I'm just watching. Because each time you operate, you're causing additional dry eye, ptosis, all that goes with it. Because of the need to remove all of them, so it's morbidity from surgery as well.
Yes, and the thing is, it's like when I removed the lesion, it looked like I did remove it in block. But then that's the thing, it's so, the adhesions to the deep tissues, and it was really posterior, and so it's really challenging even to remove this recurrent lesion. It's not like the primary lesion, it's really, really difficult.
Yeah.
Even though it's
they are challenging.
They are challenging. In the imaging, they look like a very well delimited lesion. In fact, they are hard to remove. Yeah, so.
Okay. I have a question for Augusto. I love this idea. So I do. I'm sorry. I love your idea because I think it's so difficult to achieve to keep the eye center in the third nerve pulsing. And I want to ask you, do you overcorrect? Do you put tension on your muscle to overcorrect the anisotropia?
Yes, I think you're right. You have to overcorrect, and as the superior muscle bed is there, it's easy to go back there and do a little bit more because the muscle is already there. And I think that the key issue is to put your suture back in the muscle to have a nice angle of rotation. But I'm still learning.
Please, I don't understand. You cut the pulley?
No. Before, under the trocar.
Okay, under the trocar.
Yeah, where the anterior etymonial artery enters.
Oh, yeah.
The muscle is there. Yeah.
And I want to just finish by giving my own little story about Danielle. I'm from North America, so we didn't have nearly the exposure that most of you people from South America and Europe have had. But I met Danielle, actually, one of my first fellows was Martin Devoto, who went back down to Buenos Aires. And we all know what it's like when there's a new kid in town. Everybody sort of pretends like they're happy to see you, but they aren't. But when Martine was down there and I met Daniel the first time, Daniel genuinely was. He was just a very generous person, very warm spirit, and very interested in exchanging ideas. And he did nothing whatsoever to try and suppress Martine's career. And in fact, he was helpful to Martine. And that, I think, just speaks to the sort of gentleman that he was. And let's hope we can keep that image in our minds when we have the next new kid come into our town. So thank you again, Luigi, and everybody's attended.